The way I would like to encapsulate this track is taking a little bit from all of our presentations to kind of illustrate how did we get here, starting really in the far past when humans had a fairly good physiology because they were eating food in its most primitive way. And then we developed tools and fire and ways of cutting and preparing it. So we were able to eat more food, benefit from it from in its nutritional standpoint, but something had to give away. So we developed more systemic issues. And fast forward to now, where food is really, as one of the themes of the AAMS is, food is not really food. And so we see now all these, and not just anatomical changes, but physiological changes that impact the basic functions like breathing, like chewing, like swallowing, like developing ourselves. And of course, then they affect the gut biome, and we go into systemic diseases and impacting really our systemic health. So, in the future, we don't see any improvement of this unless we recognize that we had to start with basic concepts of physiology in order to really heal ourselves. We have to go back and review our breathing, our breastfeeding, our weaning, chewing, eating, and posture, and all these things. And I want to encapsulate also this track with a saying that I knew when I lived in Italy, and I don't know where it's coming from. And it says, make food your medicine before medicines become your food. And so this is basically what this track was all about it. And so I would like to now remind the panelists and everybody else that we are kind of trying to answer three basic questions. One, what was the main problem that you identified in your presentation? Two, what is a solution that you proposed? And three, how is this gonna tie up with everything else, and what kind of message you can bring up that can be included in a white paper, and kind of how things are gonna be tied up with all the other presentations, and even callbacks to other tracks. So I would like to give Dr. Lustig the first pass. So Dr. Lustig, what can you tell us?
Thank you very much, Lucia. So I'm a pediatric endocrinologist, and I am still trying to figure out how I am at this meeting. I got here through the back door very clearly. I want to change, I want to, shall we say, adapt one thing that Lucia just said, and that is that food is medicine. Good food is medicine. Bad food needs medicine. And that's something that's been wasted on the populace thus far. And now we're getting to the point where the question is now, okay, if good food is medicine, what's good food for newborns, infants, and toddlers? And Kevin Boyd and I had, shall we say, 10 years of discussion on this, and we came up with our plenary to try to address this question. And I'm going to just show you really four quick slides to make it very clear what I think the problem is. And let me go ahead and share screen here. Okay, and I know that I'm on a timeline, so I don't want to overstep my bounds. But can everyone see it?
Mm-hmm.
All right, so on the left, we see malocclusion frequency in China. On the right, we see obesity in infancy and in toddlers in China. And they are going up commensurately at the same time. The fact of the matter is, it's going on all over the world. So Malocclusion is an epiphenomenon of airway dysfunction. And airway dysfunction is a primary driver of obesity via the phenomena of sleep apnea. These three things are tied together inexorably, and we are seeing the problems manifest now in children. And the question is why? Well, here in China, it's because of this. It's because of their nutrition transition. The question is, once upon a time, there was no baby food, okay? There was no Gerber, there was no beech nut, there was no Vitamix, there was no Breville, there was no Magic Bullet, there was mothers. And this is how they fed their children. And that basically exercised their masseters, their pterygoids, their temporalis to increase palatal vault expansion, to increase airway oxygen transmission. The problem is, here's what baby food looks like today. And so when we talk about nutrition and we talk about nutrition for babies, it's not what's in the food, it's what's been done to the food. And that is really all I have to say. Thank you.
And that's absolutely perfect and kind of dovetails in what both Jill Rapley and Mark Cannon also kind of introduce in their presentations. So Jill, would you like to say something about this aspect, since you are the queen of baby-led weaning, which I just respect and really espouse?
Yeah.
Go ahead.
Thank you. Thank you to everybody for allowing me to be part of this. I too feel like I got in by the back door, because until I was approached some years ago by John Mew, I had no idea that what I was talking about had any connection with really the oral development. If I can just refer to what I wrote, what do I see as the problem? In spite of the fact that the recommendations about introducing solid foods have changed, and we now recommend that babies start from 6 months onwards, we're still finding that most babies are started on pureed food, and some of them are on those foods for many, many months, well into toddlerhood. And whether that's in many countries of the world, some that make their own porridges and gruels, and others that buy it off the shelf in the supermarket. And that tends to mean, as I now understand, that they will tend to suck persistently, because they will usually suck by default when offered a spoon. They have very little mouth time, they swallow rapidly. That has implications for the total intake, as well as for what we're talking about here, which is the musculature and the bony structures of the face. So minimal jaw movement, no chewing, minimal tongue movements, lack of stress on those oral structures. So it almost certainly contributes to suboptimal development. And given, as you mentioned, that we have fewer, worldwide a decline in breastfeeding, which is the kind of precursor to all of this, then it's not surprising that we're seeing some strangely shaped jaws. And we have the impact on occlusion, on the airway, and on the baby's intake, and therefore obesity, which in turn has an impact on the airway, and so it goes around. Plus, the purees have more free sugars in, whether they're homemade. The act of pureeing releases free sugars, so we've got an impact on dental health. To say nothing of the things which are my own personal greatest interest, which is in how babies are learning about food, and their opportunities for development in terms of dexterity, hand-eye coordination, all of that. I absolutely echo what Dr. Lustig had said. The only thing I would take small issue with is absolutely pre-chewing and mouth-to-mouth feeding from mother to baby, but let's not forget the agency of the baby. I'm absolutely certain they didn't receive all their food that way. They reach and grab things, they take it to their mouth. They're primed for investigating their surroundings via their mouth. And that's how they discover food, by accident. For the baby, it's not about hunger. So for me, the solutions to this would be to try and spread the word about introducing foods to babies by letting them feed themselves, by offering them foods that are graspable and chewable, and giving them agency in their own eating. Healthy foods, obviously, and family meal times so they can copy others and learn social skills. In terms of what should go into a white paper, I'm not entirely clear how that would work, but we definitely need to address the issue of feeding from birth. So that's breastfeeding followed by a more natural introduction to solid foods and getting away from doing things to babies and giving it back to them. Thanks.
That's excellent. And actually, if I may do a kind of a segue to that, one of my presentations was about the importance of chewing gum, in this case, in recovering faster from different type of surgery. And that kind of underlines how important is chewing, which starts really as early as possible, because it's one of our necessary functions. And also tying to this, the importance of chewing food properly so that you don't choke on food, since choking seems to be a problem that is increasing rather than going away with softer food. So it kind of, acquiring good chewing from day one, basically, it's a skill that we need to preserve in order to keep ourselves healthy as long as possible. And let me tie that to Dr. Cannon, who had a wonderful presentation, and I thank you for that.
Well, thank you so much.
You
Yeah,
touched
and
a lot of these topics. Go ahead.
so here's the little story a little bit behind that too. My youngest daughter is a pediatric ICU nurse, and they have many, many choking cases coming in, and a lot of kids are dying because of, again, improper width development, improper swallowing patterns, improper everything. It's very, very tragic. That you're absolutely 100% correct. The wrong foods have created all this issue, and this choking hazard gone up. So I've been a pediatric dentist for 42 years, and I have been very strongly educating all the parents in my practice. It's what I call one of the most important things we can do. So you ask, what are the top things? Well, we have to educate parents because kids' lives really depend upon it. I see so many kids come in with airway problems, frenulum problems like you cannot believe, but these are systemic problems causing a systemic disease that is also causing other systemic disease. It's all correlated, so we have to work as a team, because as specialists, we've been really guilty of only seeing our own trees and not seeing the forest. And that's true in pediatric dentistry. That's true in ear, nose, and throat. So Dr. Julie Way yesterday gave a great presentation, and she's a ear, nose, and throat specialist. And something that really drove home that you're going to love, Robert Lustig, is the fact that all these high sugar pureed foods that you had just been talking about actually create quite a bit of acid reflux disease in children. And this acid reflux disease greatly increases, Kevin, the caries rate that we see, because it changes the microbiome. You completely change the microbiome of the oral cavity, of the pharynx, oropharynx, completely with this acid reflux going on. And yes, we see all these babies being put on proton pump inhibitors. How is that natural? We've gone so far away from natural that we don't see that all these new foods coming out, and you're right, they're packing the shelves now with all these new puree foods, are causing a massive amount of acid reflux disease being treated by medicine. And it's really funny because in my practice, I see it all the time. I just put them on kefir and it seems to go away. I mean, I know that's kind of crazy, isn't it? But try to reestablish a microbiome, try to get back more normal foods. And all that is so very important, because there's things that we have evolved to do that we can't change. That's why I always break things down into there's systemic and there's environmental. And with the things that are systemic, that are genetic, like the increase in brain size and all that, those are things we're not going to be able to work on. But what causes systemic disease and the environmental local issue, one thing is diet for both. So if we work on both at the same time when we talk about diet, and that comes down to education. And if you give the parents information, they then have the obligation to do the right thing. 90% of them don't know what the right thing is.
Well, yeah, I couldn't agree more, but it's more than that, because we've got marketers who are basically marketing, shall we say, pureed foods, high sugar, because that's the way they can hide it. They can't hide it if it's solid. They can only hide it if it's pureed. And of course, the kid likes it because, after all, we're addicted.
That was actually my next point, was the ton of misinformation out there, which actually comes from some of our specialists too, Robert. I mean, I have pediatricians telling the parents all the wrong things.
So
If I say,
the question is, the reason this has taken hold in the newborn or infant parent zeitgeist is because they're afraid of their kid choking. So the question is, do kids choke? Did they choke in the past? And I would love to see a secular trend in ICU admissions due to choking over time.
Jill Rapley can really address that. I can tell you, I've learned so much from her about that. I mean,
yeah.
Jill?
I think absolutely. We have this horror, this scaremongering that kids are going to choke. Well, one of the things I've seen is that when kids put something in their own mouth, especially tiny babies, they're holding on to one end of it. And if it makes them gag or something, they pull it out. When they have a spoonful of food put in their mouth, they're stuck with that. They can't control it. They can't deal with it. I've also heard time and again from parents of babies, of the children who, when they're toddlers, if they were allowed to feed themselves when they were tiny, they're no longer interested in putting stones and marbles and Lego bricks in their mouth. They just don't seem to be thinking that way at all. And yet all their little contemporaries, that's what they want to do, because it's not just food, of course, that's a risk for choking. But I think we're bypassing the period where they could be learning to chew without needing to swallow, because the chewing mechanisms start first. And if they start by feeding themselves, then most of the early foods just fall out of their mouth because they actually can't make a bolus, take it back and swallow it. They're practicing those chewing skills in advance of needing them.
Jill, did you once teach us that the pinch reflex and the gag reflex are pretty much in concert for one another, that a child's pinch reflex really becomes unable to grab something that they can choke on? I mean, there was something, maybe that's oversimplifying, but.
Yeah, it wasn't so much related to the gag reflex, but absolutely, a baby of, say, 6 months can't possibly pick up a pea. I have a lovely piece of video, I can't have time to share that now, but of a baby picking up a blueberry, and what happens if it ends up in her fist, and she takes her fist to her mouth, but at 6 months she can't open her fist to get at it, so she can't get it into her mouth. The risk comes when somebody else has put something in the baby's mouth. Or when the baby's being hurried, or all of the things we use to try and get kids to eat are distracting them from concentrating on the job in hand. So we've got songs and games and screens and all sorts of capers going on, instead of allowing them to actually focus and eat mindfully.
I also, if I may say something, I think we have a lot of education to do, because I still see even professional papers in which they recommend to cut the food in small pieces for children, when in reality small pieces are, especially meat or something, is even less controllable by a child. So it's kind of they're eliminating chewing altogether, as if chewing is a bad thing, when in reality we know, and we have to somehow transmit this information, that chewing allows the proper salivation, the proper collection of the food, the proper grinding, etc., etc. So chewing is really, it's missing right now. Even the food that you buy at the supermarket, the fruits and vegetables are selected based on how easy it is to chew them. And so this is something that it's accelerating, and both Dr. Lustig and Dr. Cannon have been mentioning the food that is now, it's pureed, it's that is an advertisement campaign. You don't need to chew your food anymore, you can drink it. And I'm just horrified, honestly. Yep. But before I go back to you all, Sharon, what is your take on this? You have to unmute yourself, Sharon.
There you
Oh,
go.
there's a lot that I can say. Thanks, Leisha. Well, first of all, I have to say thank you to you and Dr. Kevin Boyd, because I think you were the one that got me interested in chewing about 7 years ago, and you know, made those connections between craniofacial growth and development that underpin airway development, which leads on to sleep disorder breathing, which we know is a global epidemic. And I mean, chewing is like lost wisdom in society, like nasal breathing and like breastfeeding, but it is one of those lost arts. But it truly is an epigenetic force that has to be brought back into children's lives, our lives, not just in children, not just in babies. And they should be chewing by 6 months, we know that. But it's one of the top forces to grow the airway. And I think that there are a huge set of problems around chewing. The poor pre-preparation for chewing, like the shortened gestation periods for babies, so that they're not as prepared for breastfeeding after birth. There's simply not enough chewing for some of the reasons that you've just mentioned in the modern world, where food is not food, it's liquid. And then poor chewing habits, technique, and efficiency. So clinically, what I see with a lot of kids is that they simply bite off a large bolus and chew it without, and swallow it without chewing. So in terms of fixing it and what are the solutions for this, it's the first thing I would have to say is it simply is not just about exercises. I think if we're going to reintegrate chewing into daily life for the everyday person and address chewing as a clinical disorder, it has to be fully integrated into the other upper airway functions, particularly swallowing and breathing. And that the program to correct chewing, it's not finished until it's fully automated into daily life. And that's the thing that exercises doesn't do. There has to be a way of pulling exercises for chewing into everyday meals and snacks and everyday thinking until it's fully automated. Yeah, I mean, other problems that we have is it's a social problem. Everyone's in a hurry. The family dinner table's disappeared. You know, eating's rushed, or it's in front of the TV where there's poor posture. And I'm going to hark back, I think it was Dr. Lustig who started to talk about the multinationals. This is possibly the biggest problem of all, because they are big economic machines that drive the sales of fast foods, purees, processed, packaged foods, additives, sugar. It's toxic thinking.
Oh, have you seen the Ore-Ida, I doubt it, commercial where there's a family eating and a little girl refuses to eat her vegetables? So they say, save the meal by giving the child a French fry. And they
Wow.
bribe the child. Have you
No.
seen that commercial? It's horrible. Kevin, you've seen it, right?
Wow.
I see him laughing, but it's unbelievable that there's that commercial out there where whatever happened to parenting? I always
Oh, that's a
raise
whole
5
other-
kids. You just eat the food I made.
Yeah. Yeah. Look, I haven't seen that commercial. I haven't seen anything like that in Australia, not that I can think of. But I think, you know, media and multinationals is a really, really big part of this issue. And that is really, who's brave enough to take on the big boys? That's my question.
We are.
Big boys and girls. Sorry, I shouldn't be sexist, the big boys and girls. Because I think our solutions really lie in the public health campaigns around changing culture, behaviour, thinking, but daily life as well for parents and families. And I can only speak at this point from the Australian track record for public health campaigns, but we've had some absolutely wildly successful public health campaigns for anti-smoking, for the AIDS, for Life Be In It, Norm, Get Off the Couch, and there's others. And I think
you were
the public
the
health,
source of seatbelts.
say that again.
You are where seatbelts started.
We do, and our kids all wear bike helmets.
Well, but it's the point is it started in Australia. Australia has always had wonderful public health, and all you have to do is look at John Howard, okay, the most conservative PM in the history of Australia, and he got rid of guns, and he said very specifically, it's not a liberal problem, it's not a conservative problem, it's not a Democrat or Republican problem, it's a public safety problem. And so Australia is to be commended for its public health capabilities and messaging. Unfortunately, the United States doesn't listen to anyone.
But if I may say something, I think some changes also have to start with us professionals. We should know better, and I'm saying from the perspective of a speech pathologist. I worked for many, many years in hospitals and nursing homes. And of course, I went through the learning process, both in Italy and United States. I can tell you that chewing is never, ever mentioned. It's all about dysphagia. It's all about swallowing disorders. Chewing is like an afterthought. And so, and now that I've been involved with chewing for so many years, and I see the benefits and the connections that chewing makes with orthodontists, with pediatricians, with ENTs, with sleep disorders, etc., with breastfeeding specialists, with anybody, I see that we have to educate ourselves in how can we include this in our own practice and then educate our patients. And yes, we can do local campaigns to promote better chewing because of the salivation and blah, blah, blah. And we can, do what we can. I like what and yes, Jill, I'll get to you in a second. I like what Mark and I had a discussion many years ago. I was more like bottom-up approach, and he said, no, you only change if you go top down. Okay, so but he's the one that can make it happen. I'm more like convincing one patient at the time, one colleague at the time, one student at the time. But I think we have a tremendous power just as professionals to make something happen. And the fact that we are a multidisciplinary community and we are getting bigger, we are connecting to more and more subspecialty of medicine and health. This would be very beneficial to us and to people in general. We also have to make it not just a Western culture change, but we have to come up with something that is absolutely low tech, inexpensive, that can be spread to all the developing countries, or develop but with not a good budget. So we have to think in terms not just for ourselves, what is good for us, but what is good for the rest of the world. And Jill, yes, you wanted to say something.
I think we could start by maybe rewriting some of the textbooks, because so many textbooks about how oral skills develop assume a spoon. They talk about the lip clearing and these things, which if you never had a spoon in the mix, surely, how can we relate everything to a spoon? A spoon, babies are not born with a spoon. So we need to look at how those skills might develop in the absence of the use of spoons. And maybe we will see things developing in a slightly different order, some things before others instead of after, and certainly a different pace. I know several speech and language therapists who tell me that they see rotary chewing in babies who are much too young, according to the textbooks, to be doing that. Right. So maybe that's going to take some research. But
and if I may say one more thing, you're absolutely right. And again, sometimes I think we are in a bubble and we don't see what other countries are doing. But Chile, for instance, has been promoting the traditional weaning of children for years. And so the dental community over there, the speech pathology community, are looking at their children who grow in areas where there are no spoons, literally, or there are no cups, no sippy cups. And they're saying, hey, these kids are just thriving, they're doing great. So why should we replace this way of doing thing with, what is more convenient for mommy or for the international business, but is not good for the development of
If
children?
I may jump in on that,
Go ahead.
I just completed quite a bit of a very interesting study, the most complete using metatranscriptomics of the salivary samples from kids in the United States, kids with autism in the United States, comparing them to kids from blue zones in South America. And the taxa shift from being in the United States is hundreds of different taxes of shift, and the functional groups using KEGG orthology, massive changes in the functional groups. So all epigenetic factors are completely wrong. And a lot of the bacteria we're running into are very, very specific to areas of modern world where they actually do things like break down your neurotransmitters. They actually release enzymes that destroy neurotransmitters and they get into your bloodstream. So these are really very interesting things. We got a tremendous paper coming out on it, and so yeah, we got to almost preserve these areas that are like blue zones, a bad term to use, but they can show us so much health, and they're rapidly disappearing, as Dr. Lustig brought up with China. All these areas are rapidly changing, and they're before your eye. You see all this new stuff coming in, and it's all this junk food coming in that they didn't have before.
Right.
China's a microcosm of what's happened in the United States. It took us a little longer, and we don't have the data from back in the 50s when things started. So, they're more compressed, so it's easier to see.
Yeah.
Kevin, we had a discussion offline previously. My question to you was, if you look at the airway and at the palatal structure, the vault, the maxilla, the malocclusion of babies that were fed by gastrostomy from birth because of intestinal problems that required going past the mouth. What do you see in terms of changes in facial architecture and then changes in systemic health going forward?
You and Mark, also as a pediatric dentist, we see more special needs kids that might have been subjected to this.
Yes.
It's almost universally bimaxillary transverse deficiency and anterior open bite, because there's just no stimulation of the craniofacial respiratory complex early in life. And I've done a little digging since we talked about that. And Mark, would you agree? That's probably...
Oh, yeah, absolutely. In fact, I remember going back a long, long time ago that we were discussing all that in the early 80s and working on issues and making special appliances to help that not have that not happen to all the neonates and everything. I still go to the neonatal unit, the one out by me that's run by Children's, and I'm just amazed at what goes on and what they don't seem to realize at all. They're the neonatologists. You start to talk to them about that, they have not a clue what you're talking about. But then we've seen it.
Well, I
Right,
believe
Kevin?
they don't have a clue, and I've worked in academic medical centers for a long time, and I agree they don't have a clue. Here we were talking about changing medical education, changing the textbook. You're not going to be able to do that until you bring these people on board. And so the question is, how do you do that? What kind of research do we need in order to be able to do that? And the only way to do that is with longitudinal data. You're never going to do that with cross-sectional data. So
and really what you've described, what you've described, Rob, with kids who don't get stimulation to the craniofacial respiratory complex early is an accelerated version of what's gradually happened to humans over evolutionary time.
Yes.
Is that lack of stimulation by hunting, gathering hard on processed foods, but you're seeing it in an instant accelerated in kids who are not being challenged by nursing, weaning, and gradual lifetime commitment to eating fresh, hard, resistant food, which is what if there's time left, I want to show a few slides about that, but if there's not, that's okay.
I have a question. Do you think the medicalization of weaning and breastfeeding and eating had an impact in which, you know, we think about safety of the baby, but not really? I mean, I excluded children who actually have real problems. But the fact that, you know, there is this industry that thinks about safety for people or more efficient way of eating when, you know, the fast food, when in reality, you know, has nothing to do with respecting physiology. So could that be a problem, the medicalization of normal functions? Yes.
Oh, yeah, for sure. I mean, infant formula is given at the hospital. They've medicalized, giving birth. They've medicalized infant feeding and weaning. So, oh, absolutely, Alicia.
And they get it for free. Yeah, I mean,
Yeah,
like
free.
I know that they get all that formula given to them for free that has all those wonderful corn solids in them that we all love.
Right. Jill,
Because then they've got you for 6 months.
Yep. Yep.
I think we can go back to, sort of the early last century when doctors really began to take over infant feeding, and they were advising women. So you have Truby King talking about feeding every 4 hours and so on. So then breastfeeding failed because it doesn't work like that. So then the formula companies kind of leapt into that gap. But I think it was created in the first place, unfortunately, by medics.
Right. And plus other moral barriers, like, I remember when I was a kid, at least in Italy, women were able to breastfeed and nobody was paying attention. But now you have to hide yourself. You have to go to cubicles if you are at the airport. You have to cover yourself with a blanket or something. So breastfeeding is becoming almost like inconvenient. Therefore, baby formula works better, and that sets really a cascading effect that can last a lifetime. And I think again, it's up to us to educate the public. Is there one more, let's say, wrapping concept that how do you see, one more time, chewing and nutrition and systemic health wrapped together?
Mark has a comment.
Come
Thank you, Robert. I just want to say all of you guys are heroes for me, and really the possibility of us wrapping our heads around the connection between nutrition and chewing and craniofacial morphology and systemic health is brilliant. I'm aware that I don't have the lights on, Samantha. I don't know what happened to them. Thank you for your eye.
And Mark, you said craniofacial respiratory is what you meant, right?
Well, craniofacial respiratory. I was using a mesh term, a medical subject heading term from the National Academy of Medicine.
Yeah,
we can work on getting your term into the National Academy of Medicine's medical subject headings, and I'm sure we can.
You can.
So,
and by the way, I'm sorry, Mark, I want to interrupt you. Correct me if I'm wrong, but in the ICD-10, there is no mention of chewing disorders, unless it has to do with chewing tobacco. Go ahead.
Yeah, there's
okay,
also
thanks.
no
I just want to finish this thought. So I so appreciate everyone's enthusiasm, but when I was at the World Oral Health Forum, I was actually, this is a think tank for the World Dental Federation. And the World Dental Federation has over 200 member societies. It really represents the, you know, kind of world body of dentistry. American Dental Association is just one member. And so there's a think tank that sets policy strategically as a steering guide, and it's called the World Oral Health Forum. And they published a series in the Journal of the American Dental Association, 2016 to 2017, with the lead author being the editor of JADA, Michael Glick, who, by the way, won an award for collaboration at our 4th AAMS Hippocrates Gala, along with Robert Lustig. This forum, they have a symposium that looks at, you know, issues, and it's kind of a public facing thing. And I was asked to present on their Congress in Shanghai this year, and that meeting was canceled. But one thing that came together was seeing David Williams get up and speak with a panel that Michael Glick was moderating, and they co-chair this. And I saw him talk about the critical importance of going after organized processed food. And I thought, aha, I've got to get Robert Lustig together with, you know, David Williams and Michael Glick. And maybe this is the hook that's going to get us into updating the definition of oral health. So at least I've got it on the agenda for the 2030 Horizon Strategy Group. And I know Robert's participated in some very excited meetings with the leaders of this think tank. And I'm really excited about the possibility of helping advocate for all of your panel's work. But I just wanted to interject that. And one last thing, nutrition and chewing has been sorely lacking from the myofunctional therapy curriculum, such as it is. And we have an exciting announcement about educational competency coming at our opening ceremony. I think this is something we absolutely need to focus on.
I will tell you, Mark, that my conversations with Michael Glick and David Williams have been fruitful, but they have really only centered around dental caries. They haven't, you know, gone to the level of, you know, discussing, you know, the pureeing aspect of things, the airway issues, you know, that is yet to be tackled. So
we have an ally in the World Sleep Society, which is a partner of ours, as you guys know. They would like to and have a concerted effort at getting sleep on the agenda for the World Health Organization for the first time ever.
Oh, that's fabulous.
And so if we're collaborating in these efforts, I think the World Oral Health Forum, which the World Health Organization sort of adopts their guidelines, just sort of, you know, de facto, I think we have some exciting opportunity because the World Sleep Society has welcomed us in and embraced myofunctional therapy so amazingly for several congresses now. I think we have an opportunity to push that a little bit further up the hill.
I don't know if anyone talked about it at the meeting, but what do you know about the COVID-19 mortality rate on patients with actual sleep apnea?
There's a presentation that is a special presentation, featured presentation from Mayor Krieger on the subject in our Congress program. Great.
Because I've been hearing some things out there about it, and some people reporting on some potential studies coming out. You know, this embargoed information right now because they're publishing. So I didn't know.
The question is it a phenomenon or an epiphenomenon? I mean, remember, OSA goes along with all the other systemic.
I know.
And we know that, you know, all of the metabolic syndrome is a primary driver of mortality due to COVID-19
But you could use that. Yeah, you could use that with the World Health Organization if you found that there is some type of association. Yeah.
Excellent. I think this is a great wrap for this session, and I think we are within the right time. So I want to thank everybody for your participation. I loved your presentations, and hopefully this is gonna bring forward more education and the change that we really need right now in our society, for ourselves, for our offsprings, for our patients and everybody else. So Thank you so much. And Mark, do you want to close the session or
Or
do you want me to
Samantha?
do it?
Yeah, I just want to say thank you to everyone. This is a subject close to my heart, and I know a lot of moms out there can also relate at the disinformation coming from many sources. So to have these experts here who are feeding into the pot of what the science shows us and how we need to get mothers more support so that they don't have to go back to work after 6 weeks and put their babies on pureed foods. So there's a lot of avenues of how to implement the science and how we can change society and culture. So I just want to say thank you to all our panelists. You've really given this topic a very well focused lens based on your discipline, and it's wonderful. So thank you again.
Thank you all.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Bye.
See everyone at the top of the hour.